Okay, hi everyone. My name is Jessica Tobin, and I am here, and we are all here today for Exploring Women's Health in LAM by Dr. Simon Johnson and Dr. Lisa Larkin. So if you're in the wrong place, now's the time to run. So, like I said, my name is Jessica Tobin, and I'll be the session chair for this next hour. This session is near and dear to my heart. I was diagnosed with LAM with a AML rupture when I was 14 weeks pregnant with my first son, my only son. But I'm also a women's health nurse practitioner, so it's my field as well, which I appreciate very much. To help the LAM Foundation improve speaker and topic selections for future LAMposiums, we request that you complete the evaluations for the session. I'll pass them out during the speakers, and then just make sure you get them back to me at the end, or there's a box at the back and you can place them in there as well. I'd also like to thank our generous sponsors and partners who have provided the financial support to make this conference possible. I'm going to start with first Dr. Simon. He's a professor of respiratory medicine at the University of Nottingham, UK, as well as a director of the National Center for LAM in Nottingham. Dr. Johnson's research group worked on proteolysis and mechanisms of lung destruction in chronic lung disease and has a program of basic, translational, and clinical studies in LAM. And then our second speaker is going to be Dr. Lisa Larkin. She's been practicing internal medicine and women's health in Cincinnati for more than 20 years. She's an expert in the area of women's health, specifically midlife health issues. She is the owner and president of an independent multi-specialty practice offering direct primary care, concierge primary care, and women's health. Please welcome Dr. Simon Johnson and Dr. Lisa Larkin.
Well, thanks very much for that very kind introduction, and also highlighting one of the things I'm going to say, that pregnancy can be associated with rapid increase in angiomyolipoma size. So I've been asked to talk about women's health in LAM. I'm a LAM doctor from the UK, and this is the LAM Foundation's International LAM Clinics slide from their website, and that's me with a little arrow in the UK. Nottingham's most famous for this person. Anyone know who that is? Robin Hood, yeah. We also like to think we're well known for our LAM clinic. We run the National Centre for LAM. This is a centre manager and our nurse specialist. And even though it's a long way from here, we get quite a lot of high caliber LAM visitors. Dr. Moss, Sue Sherman, Dr. McCormack and Holly have all visited recently. So that's me. What I'm going to talk about really is the relationship between estrogens and pulmonary symptoms in LAM. Now, as I'm not from around here, and I call estrogen, if there's anything else you don't understand in my accent, please just interrupt me, or in fact ask any questions as I'm going along, that's fine. So I'm going to talk about something to do with breathing changes in relation to menstrual cycle. I'm going to talk about the relationship between the menopause and estrogen levels and what happens to lung function in LAM. I'm going to talk a little bit about the efforts people have made in the past to block estrogen with medication to try and improve LAM. I'm going to talk a bit about what evidence there is in LAM in pregnancy. There isn't a lot of real clinical trial or hard laboratory evidence for any of these things. And most of the data I'm going to show you is from retrospective studies. And although it's probably the best data that we have, it's not hard and fast. And it also is general data. So if you're thinking about your LAM compared with the data that we show, and you think, well, maybe I'm not being treated that way, is that wrong? It's not necessarily wrong at all. Everybody needs to sit down with their own LAM specialist and just talk about their problem. But what I'm going to talk about is an overview of what we think we know. So the first thing to say is estrogen really is the sort of elephant in the room of LAM. We've thought for a long time that estrogen had a bearing on LAM. LAM's a disease that almost exclusively affects women, usually presents before the menopause, and even if it presents afterwards, you probably had LAM before the menopause. The symptoms may get worse throughout the menstrual cycle, and the disease can be affected by pregnancy, as we've already heard today. So virtually the only things we do know about estrogen and LAM is that LAM cells are capable of responding to estrogen. This is the only sort of lab slide I'm going to show. This is a photomicrograph of a LAM nodule, and the estrogen receptor, the little chemical receptors that respond to estrogen when it's in your bloodstream have been colored green in this, progesterone red, and if the cells have both, then they're yellow in this slide. And you can see that most of the cells in this little LAM nodule have the capability to respond to estrogen. And this is an experiment from my lab where we've given animals LAM-like tumors. We've either not treated them with estrogen, which is a control line which rises up slowly, or we've given them estrogen, and you can see the line rises up faster, tumors grow more rapidly. And so we think LAM cells can respond to estrogen, and that estrogen is likely to be bad for LAM. Of course, women with LAM are not laboratory animals, and so the data is likely to be different. So I'm just going to talk through these 4 areas now. And the first thing I'm going to talk about is the relationship between LAM symptoms and the menstrual cycle. So I look after a couple of hundred people with LAM in the UK, and I quite often hear people tell me that they're more breathless at certain times throughout their menstrual cycle. Sometimes they get chest pains at certain times in their menstrual cycle, and 1 or 2 people, and I'm sure, I don't think they all talk to each other about this, say, I'm sure my pneumothoraces happen at the same time of the month in people with pneumothorax. And actually, if you ask everybody with LAM, if their period affects their LAM symptoms, around a fifth, maybe a few more, will say that it does, although a significant majority will say that it doesn't have any bearing. And in fact, if you go to the poster session today, you'll see that Nishant Gupta, who has posters on nearly every aspect of LAM actually, has a poster on menstrual variability in LAM symptoms, which sort of backs up what I was going to say, fortunately. But that's quite a nice poster if you want to check that out later. So around a fifth, maybe a few more people with LAM will say that their symptoms are worse throughout their menstrual cycle. So why might that be? This little graph here, or chart, is a graph of the different hormones and how they change throughout the menstrual cycle. I'm just looking for the pointer, which isn't appearing, but the left-hand side of the graph would be day 1 of the menstrual cycle. And if you just follow the estrogen line there, you can see that it's fairly low throughout the first part of the menstrual cycle, then it comes up quite rapidly in the middle, and just after that point, that's when you would have your period, bleeding would last for a few days, and then the second half of the cycle, estrogen gradually falls. So most people report worsening symptoms in the middle of their cycle, especially just before bleeding, when suspiciously estrogen levels are higher than at other times. And this is quite a common observation. Is there any hard evidence of a relationship between estrogen and lung function in LAM? And at the moment there isn't. And I think one of the reasons for that is quite difficult to do these studies. If you want to see how someone's estrogen's changing, you have to come up for a blood test every day of the month and have their lung function measured all of that day. And I guess you've all got stuff to do, really, haven't you, apart from that. So it's quite tricky to do those sorts of studies. There's a little bit of evidence here and there. This CT scan that's on the screen now is a coronal section. So a picture from the front of a woman with LAM. This is from a paper by Dr. Moss's group. And what you can see, the little space between those 2 arrows there is a large lymphatic mass, a lymphangioliomyoma, and about 20% of women with LAM will have. And that CT scan is taken at day 1 at the menstrual cycle. And then they repeated the scan in the same woman in the middle of the cycle, day 14, when the estrogen peak is there. And you can see that the arrows are quite a lot further apart on that one. And this abdominal mass had changed. And I think this woman had variation in her abdominal symptoms due to LAM throughout her menstrual cycle. And you can see that the This lymphatic mass got bigger and again shrunk afterwards in relation with estrogen. So this is obviously an abdominal symptom, but people do seem to think that their respiratory symptoms change. So if you have that, that's not an unusual thing. What's interesting is why only some people will have those symptoms. And we don't know whether that's because their estrogen levels are higher, because they're naturally more sensitive to the effects of estrogen, or whether they have more active disease. We don't really know why this is. There's some anecdotal evidence to suggest that if these symptoms are difficult, that suppressing your menstrual cycle through different methods, and there's different ways you can do this, but people tend to use progesterone, and if you use a progesterone implant for contraception, which suppresses your menstrual cycle, you also hear anecdotal reports that this menstrual variation in symptoms goes away. And again, this is, I'm not suggesting that people have treatment for this with progesterone, but it's likely that suppressing estrogen will reduce this monthly variation in symptoms. And in fact, Dr. Gupta's poster that I was talking about earlier does suggest that people report that this is the fact. What also is interesting is that when people get treated with rapamycin, the menstrual variability is still there. So it's probably independent of mTOR. So LAM symptoms can vary with a menstrual cycle, not in all patients, and it's probably related to changes in estrogen throughout the menstrual cycle. So if high levels of estrogen are associated with worsening LAM symptoms, when your natural estrogen falls after the menopause, you might predict that LAM might become less active. So is there any evidence for this? So if we just briefly review estrogen production, estrogen's made by the ovaries. And the ovaries make estrogen when the pituitary gland, which is another endocrine gland just at the base of the brain, produces these hormones, luteinizing hormone and follicle stimulating hormone, and that tells the ovary to produce estrogen. Estrogen's also made in adipose tissue or fat, and fat cells have an enzyme called aromatase, which can make estrogen from other steroid-type molecules. So you have estrogen from two sources. So when people go through the menopause, the ovary stops producing estrogen. The pituitary is still telling it to, but it's not listening anymore, and estrogen production from the ovary falls. And so after the menopause, nearly all your estrogen production comes from this enzyme aromatase in fat cells. And this little graph here really just looks at your estrogen levels throughout your life, and you can see the solid line here shows the estrogen level increasing when periods start at the menarche, stays fairly steady throughout your fertile period and the perimenopausal period. During the menopause, all sorts of trouble breaks loose, it goes up and down. And then things stabilize out postmenopausally. And if you notice, you don't have no estrogen postmenopausally, but you have significantly less than you had premenopause. And of course, that postmenopausal estrogen is coming from aromatase. So what happens to lung function under these circumstances? So I'm just going to talk about FEV1, which is probably the best understood measure of lung function that we use for LAM. It's a measure of airflow or airway narrowing. And FEV1 falls when you have LAM more rapidly than normal. Everyone's FEV1 over the age of about 25 goes down by about 20 milliliters a year. That's without having a lung disease. In LAM, it's very variable, although the average value is something like 120 milliliters a year, so 6 times faster than normal maybe. That's for all people, before you treat them with rapamycin, that is. If you separate them into people before the menopause and people after menopause, actually the people before the menopause are a bit higher than 120, and the people after the menopause are significantly lower. Some of these data came from a study we did a long time ago. Actually, this is the first study I ever did in LAM, a very long time ago now. You don't need to see the exact numbers, but really after the menopause, loss of lung function for FEV1 and actually also DLCO was slower in this study. Then a few years later, Dr. Moss's group did a larger study looking at the same thing, and they also saw for FEV1, people pre-menopause were losing FEV1 90 milliliters a year, and then afterwards at about 50, 55 or so. So nearly the disease was almost half as active after menopause. Same thing for DLCO, measurement of gas transfer. And then the most recent data on this, and perhaps the hardest endpoint that we've got, is a study by Nishant and Frank McCormack. And they looked in the NHLBI registry. And the beauty of this is the NHLBI registry collected data from the early 1990s, and we now know what's been happening to people. And this is a survival plot. And when the plot goes down, that means people have either died from LAM or they've needed a lung transplant. And there are two lines here. The lighter colored one at the bottom is patients pre-menopause, and you can see that goes down more quickly than the post-menopausal patients. So what all of these data suggest is that after the menopause, lung function declines more slowly than before, and that's associated probably with improved survival if you have LAM. Obviously, there are other factors because people are different. Postmenopausal patients are older than premenopausal patients generally. But on the whole, we think when I'm looking after people, if I can get them through the menopause with reasonable lung function, I do tend to relax a little bit. And so, of course, the flip side of this coin is if people have difficult menopausal symptoms and they have LAM, I always tell them not to take hormone replacement because you're just giving them back estrogen, sometimes in higher doses than they would be producing naturally, which is bad for them. And this is the area that Lisa's an expert in, so I'm not going to talk any more about that just now. So if estrogen is bad for LAM, does blocking estrogen help? I mean, you'd imagine it would, wouldn't you, really? So that's the little schema of where estrogen comes from again. And so estrogen, no matter where it comes from, acts on the LAM cells to make them grow and move around the body and generally cause trouble. So estrogen's been targeting LAM in all sorts of different ways, and you can do it at different sites. You use drugs like Lupron, you can affect the signals from the pituitary gland that tell the ovary to produce estrogen. If you use progesterone, it acts on the ovary directly to suppress estrogen production that way. And perhaps you'd imagine most effectively of all if you just blocked what estrogen did when it got to the LAM cell. Of course, it blocks it everywhere else, not just at LAM cells. That might be quite effective. And then you can also block estrogen production specifically from fat using drugs that block aromatase like letrozole. So I'm just going to very quickly run through the evidence on this because there are really no convincing studies for these anti-estrogen therapies either way. So progesterone was, as I say, suppresses estrogen production, and it was the most commonly used treatment when I started working on LAM in the 1990s. Do you remember the 90s? I don't think we want to go back there really. But there are really only retrospective studies to show whether progesterone works or not. This was one I did a while back. And in my study, actually, it looked like progesterone possibly slowed the course of LAM slightly. I'm not going to dwell on these data too much. Likewise, the NIH group did another slightly larger study, which probably some of you were in, I'm guessing. And they showed that loss of lung function, FEV1 and DLCO was actually faster in people that took progesterone. But what was true in both of these studies was that the people who were given progesterone tended to have worse LAM anyway. And so what we were probably seeing was a combination of people with more active disease having a treatment that didn't work very well or possibly at all. So I think the bottom line from these studies is there's no real evidence that progesterone alters loss of lung function in people with established LAM. It suppresses estrogen, but we don't really know why that doesn't translate into a benefit for women with LAM when they have established disease. Maybe it's too late in the disease course at that point. We're not really sure why. People have used drugs to block the estrogen receptor, and they've also performed oophorectomies, removed the ovaries to reduce estrogen production. Tamoxifen is a drug that blocks the estrogen receptor. It's a funny drug. It's called a partial agonist. When it starts working, it actually activates the receptor a little bit and then blocks it longer term. And as you no doubt know, it's a drug commonly used in hormone-sensitive breast cancer, and for which it has proven efficacy in preventing recurrence. There are really only case reports of use of tamoxifen in LAM, although you'd think it might be a promising treatment, but there's really no evidence that it's helpful. Oophorectomy was a common treatment, actually, in parts of Europe, not England, I would say, for LAM. If you take your ovaries out, of course, you still have estrogen made from aromatase in fat. And again, there are case reports only to suggest whether this works or not, and nothing conclusive. Of course, if you do either of these things, you get significant side effects of the loss of estrogen, and that might be flushing, menopausal symptoms, basically, reduced bone density because estrogen is good for promoting normal bone structure, and other things like reduced libido. Progesterone has its own side effects in addition to these, causing fluid retention and meningioma. And really, the side effects of these drugs are pretty much guaranteed, but the benefit there's really no evidence for. So most of us don't recommend them anymore, although for specific things in individuals, very occasionally they get used. Two slightly better studies of anti-hormone therapies. One using Lupron, performed by Sergio Harari in Italy. This was an open label study, so no placebo group, but they treated 10 women with LAM with Lupron for 3 years. And you can see these graphs here are the FEV1 values and the DLCO values of the women that were treated. And you see, unfortunately, they do tend to slope downwards. And although there was no placebo group, this wasn't different from other women with LAM who had no treatment. What was different was that the patients lost bone density or trended towards osteoporosis throughout the course of the study due to estrogen suppression. So side effects, but no obvious benefit from this study. It won't surprise you to hear that the best study of any anti-hormone therapy was done by Frank McCormack. That's the TRAIL trial. And the TRAIL tested to see whether giving letrozole, the drug that blocks aromatase and reduces estrogen postmenopausally, they did a placebo-controlled study to see whether that was a benefit to LAM. Unfortunately, they didn't quite recruit enough subjects. They recruited 17 women, and the trial was inconclusive. But the people treated with letrozole had a better fall in VEGF-D values, which we think is an activity marker for LAM, than the people who didn't. And when they reanalyzed the data to try and take account of the small samples by pairing up letrozole and placebo patients, it looked like the people who were given letrozole did slightly better than the people who didn't. So there's a suggestion that blocking estrogen with aromatase post-menopause might help loss of lung function in LAM. So the final thing I'm going to talk about quickly before Lisa takes over is pregnancy. And this is a really critical issue. And for women with LAM, people are diagnosed in their late 20s, early 30s. Very often they're thinking about having a family. Well, I've heard they may even be diagnosed with LAM during pregnancy. And of course, case reports have described LAM presenting or worsening during pregnancy. And women with LAM are frequently advised to avoid pregnancy because of this. And so we're just going to look at the evidence a little bit. This graph here is actually just a graph to highlight that the total body estrogen goes up steadily throughout pregnancy. So you might expect your estrogen levels are higher during pregnancy, that you might have more problems from LAM if you had a hormone-sensitive variant of that. Of course, this is a bit tricky because everyone can be a bit breathless during pregnancy. You know, there's a human in your tummy. It squashes your lungs. Work of breathing is increased. People become anemic to improve oxygen delivery to the baby. They're not so bothered about their mum. So everybody's a little bit can be a little bit breathless, whether they have LAM or not when they're pregnant. And again, there are a few retrospective studies of what happens during pregnancy to women with LAM. This was an early study we did. As we only knew 50 people with LAM at this time. 28 of them had been pregnant. Most of them, 21, had all their children before they knew they had LAM. 7 had become pregnant when they had LAM. In one case, the pregnancy was terminated. One person had an uncomplicated pregnancy. All the others either had pneumothorax, bilateral pneumothorax, chylothorax, or a combination of those things. And when we looked in detail, pneumothorax or chylous effusions were about 10 times more common for women with LAM during pregnancy than for women with LAM when they were not pregnant. The other thing that we didn't have in this study but is reported, and you've already heard happens, is that angiomyolipomas can enlarge during pregnancy and sometimes rupture. So the risk of complications during pregnancy in LAM is significantly higher. The next study that we did was actually led by Marsha Cohen, and she performed a questionnaire study. I don't know if you know Marsha. She's a researcher and also has LAM. She works out of Toronto, and she has been to this meeting before. And she performed a questionnaire study which we helped with, mostly in people from the USA, but also other countries. And really to address the effects of pregnancy in a larger number of women. And it's also quite informative to look at the people with LAM who'd never been pregnant. And a certain percentage of those had not been pregnant for the normal reasons. They didn't have a family, they weren't ready to have children, they had fertility issues. But a significant number were afraid to have LAM because of what they read about the disease, nearly a third. And a quarter of people had been told by their healthcare professional not to get pregnant because of LAM. A small number were also concerned about inheritance of tuberous sclerosis. So having LAM certainly puts people off being pregnant and puts doctors off telling people that it's okay to have children. So if we look a little bit further into the study, this is a bigger number of patients. 205 people in the study had been pregnant, most of them before LAM got diagnosed. 15 were diagnosed with LAM when they were pregnant, and 12 became pregnant after they were diagnosed. And the sort of highlights from the study really was that if you look at these columns, the one on the left is people who had pregnancies when they already knew they had LAM. The middle column, diagnosed with LAM when they were pregnant, and then the other column is people who'd had their pregnancies before LAM was diagnosed. And what you see here is that the people who got pregnant when they had LAM were more likely to have premature births. I have to say all of the outcomes of the fetus was okay. Everybody ended up with a healthy baby at the end of the thing, but it wasn't exactly their dream pregnancy, unfortunately. The respiratory complications, like the previous study, although perhaps even more emphatically, the number of pneumothorax was much higher in the people who became pregnant when they actually had the disease. So again, complications increased obstetric complications increased a little bit. Fetal outcome good. Marsha's a social sciences and cognitive type researcher, and she looked at anxiety, depression, social functioning, and quality of life as part of this study. And actually, the people who'd had children with LAM felt just as well as the people who hadn't had children. So it didn't really affect their social functioning or quality of life at all. When we looked at lung function, the highlighted column is the lung function of the people who'd had children when they had LAM, and you can see that these numbers are lower than the people who'd either never been pregnant or had completed their family before LAM was diagnosed. The last study that we did is one that's currently in progress with Dr. Moss is leading this, and we've contributed some patients. And we studied 15 patients before their pregnancy and then after their pregnancy. And what you see is that the FEV1 values on average 2.4 before pregnancy, 1.9 afterwards, and that's only about sort of 18 months apart on average, so that was significantly lower. DLCO was a little lower, but also significantly so. We looked at some CT scans. This is the same person before and after, and you can see certainly some of the cysts have enlarged significantly during pregnancy. We didn't have many CT scans before and after to look at, but there was a suggestion that the cysts had got a little worse. These are the slopes for lung function for FEV1 on the left and DLCO on the right. And the line down the middle of each graph is the time of pregnancy. So the bit on the left is before and the bit on the right is after. And it's hard to tell from here, but the slopes are a little bit steeper after pregnancy. And if you look at the average values of this, people were losing FEV1 by about 120 millilitres a year before pregnancy and 190 afterwards. So that was a significant difference, and they also lost DLCO a little faster. So it does look as if pregnancy, apart from being associated with a high risk of pneumothorax and other complications, certainly in some people is associated with slightly faster decline in lung function. I don't want to completely gloom you out about this, and just show you this lady who's one of my patients. A long time ago now, she was, to all intents and purposes, healthy, had her first child 2 days before the delivery, had bilateral pneumothorax and a chylothorax, needed bilateral pleural surgery, and then sort of gradually recovered. And I look after this lady now, and her baby is now 27. She's actually been very stable the last 10 years. She uses ambulatory oxygen for some things, not everything. She's been on rapamycin. This is 27 years after this fairly catastrophic pregnancy, and she's basically, she has a good quality of life and has been quite stable. So conclusions about pregnancy and LAM. So many women in LAM don't have children, either because they're concerned about the effects on their disease, or maybe their physician is. People often don't have children because of the TSC risk, if that's relevant. Some women have uncomplicated pregnancies, and I've looked after women who've had uncomplicated pregnancy, but it's not really the rule. And they're probably those with a milder form of disease. Pregnancy, as I said, is associated with increased risk of pneumothorax, chylous problems, angiomyolipoma bleeding, and premature births, although good fetal outcomes. There's really no difference in quality of life or dyspnea or fatigue as a result of pregnancy. And so, I mean, what I say to people when they ask me this, and whenever I see a new person, I'm sort of sitting there waiting for them to ask me about, they usually go, can I fly? And then they go, oh, and shall I have a baby? And the discussion I have with them sort of goes like this, really, that it's an individual decision. I outline the risks of increased pneumothorax and pulmonary function. I say that it's safer for those with good lung function. people with small or ideally no angiomyolipomas, and that the main thing to do is to plan everything, to book with an appropriate obstetric team that's an expert in fetal and maternal medicine, and to plan things carefully as you go. The other issue, there's a whole other can of worms, which I haven't written a slide about, is whether it's safe to take rapamycin during pregnancy. And at the moment, we usually recommend that people stop rapamycin when they're pregnant. So that's all. Thank you for listening. I'm happy to take questions now, or maybe we should let Lisa talk and then both do questions at the end. That would probably be better, I think. Yep.
Thank you. Well, everyone should feel free to stand up and take a stretch if you need to. So first, that was a terrific presentation. Thank you so much for inviting me to be here. By way of complete transparency, I will tell you I am not a LAM expert. I really am a women's health expert, and I'm going to tell you how I got involved in LAM because there are some parallels. What I do in women's health, my area of expertise and specialty is really menopause management, female sexual dysfunction, and I do a lot of cancer survivorship, and obviously a lot of that is breast cancer survivors. And that's why there's a great deal of overlap in terms of LAM. Okay, you want to tell me how to forward a slide here? Sorry. Let's see, there we go. Is that better? There you go. Okay, so what I hope to do in 30 minutes today is review the management of common women's health complaints in LAM patients. So I'm going to focus on 3 patient types, so contraception, menopause, and then women with sexual health concerns. So I think you just heard, estrogen is the big elephant in the room, and I actually think your slide was better than mine. But certainly in the overlap here is really that estrogen, for the majority of women who have hormone-sensitive breast cancer, estrogen's the big evil molecule as well. And so that's really why I believe there's a lot of overlap and why I'm here today talking to you. So what we know is that there's a lot of breast cancer survivors. I'm actually one of them. The number really is 3.1 million breast cancer survivors in the United States. Obviously, those numbers are huge compared to the number of LAM patients. And the size of the studies in breast cancer patients with hormones, which I'm going to talk about a little bit, obviously are much more robust because the sample size is so huge. But what I'm going to talk to you about today is how I believe the data can transfer to LAM patients. So I'm going to talk about 3 patients. So this is the first one, a 40-year-old woman who's had LAM for 4 years. She has irregular periods now, and she wants to talk about contraception because you just heard that maybe pregnancy is not a good thing in LAM. The second patient is a woman who's going through the menopause transition. So she's 51, she has 9 months of irregular periods, and she's having the dreaded hot flashes, night sweats, vaginal dryness, moodiness, anxiety, and sleep disturbance. And these are the patients that I see in practice day in and day out. The third patient is a 55-year-old woman who's 5 years beyond menopause. She also has LAM, and she comes in talking about low desire, severe vaginal dryness, pain with intercourse. She's tried everything over the counter, and she's had 2 UTIs, and she's miserable. So you saw this slide a little bit before about the menstrual cycle, and I want to talk that clearly there are changes in estrogen, but there's also changes in other hormones, particularly progesterone, during the menstrual cycle. And so as you already heard, women often complain of change in symptoms and lung function during the menstrual cycle. Hormone levels are really variable, and so in reproductive age women, estradiol levels, depending on where you are in the menstrual cycle, can range from 80 to 100 to 400, and I would say that just as way of correlation, it's in the thousands when you're pregnant. And so these are levels that change day to day, and that's one of the reasons that measuring estradiol practically for a regular patient that's not in part of a clinical trial really is not all that helpful. So we know that there's many stages of the reproductive stages, we call them, and I want to point out that in the teen years, when young girls go through puberty, they have very irregular hormone levels day to day, and this is why adolescence can be very challenging for young girls, and periods are typically irregular. In the 20s and 30s, this is the time of peak reproductive, peak fertility, and although I just told you that hormone levels change during the reproductive cycle, they're relatively consistent. So women will get to know their own cycles. They typically are 28 days, or for an individual woman it might be 30 days or 32 days, but they're very reliable, and this is the time when there's maximum fertility. And so things are pretty even. In the menopause transition, which is in the early 40s, through the menopause transition, which is usually around age 50, hormone levels become incredibly inconsistent, and often for patients I call this puberty part 2. So the perimenopause is very much like puberty because hormones are all over the place, and this is why women are largely very symptomatic. In the postmenopause, so after several years beyond that last menstrual period, everything quiets again. And I just told you that reproductive hormones in the reproductive years are in the hundreds. Postmenopausally, estradiol level typically is less than 20. And as you just heard, there is some conversion with aromatase in fat cells. There's also some conversion from adrenally made DHEA, but levels are vastly lower in the postmenopause. And this goes again with part of what you just heard potentially about why lung function decline slows down after the menopause. And this is just a pictorial again to say when you are in your 20s and 30s, you're cycling based on your hormone levels, but everything is very consistent and even. And so women tend to know their cycles and do pretty well. It's really in the perimenopause where everything is all over the map. And this is when I get to see patients in the office, because even though they're still having periods, they're miserable, and it's really because hormone levels are all over the place. In the postmenopause, again, things get better, and I really encourage women to hang in there because the transition, once they're beyond it, for most women is really much better. And this is because hormone levels are low, but the body gets used to it, and things are consistently low. So what about contraception? And again, I think this is a big discussion, and I will tell you I'm going to spend the least time on this topic because when I've spoken here before, this was an area of the most controversy. And I will tell you the reason is, and as you just heard, I think the data on progesterone is unclear, and I bet with among the real LAM experts, and I don't know if you can agree with me, that there's some controversy about whether or not progesterone is good, bad, or indifferent in LAM. I think estrogen is more clearly the issue. And so what are the typical contraceptive methods? So obviously barrier methods or condoms are very typical. What about hormonal contraceptives? And this is again where I think there's some controversy. So I told you that when you're having your regular periods, you are, as a woman, are making estrogen. So the question is, should we take away all estrogen? Should we give you that aromatase inhibitor, which we can't until you're postmenopause, but should we take your ovaries out? And I think the data is not entirely clear about that. And I would venture to say, in my world, premature menopause really is a bad thing for women for bone, brain, and heart health, never mind sexual dysfunction. And so early menopause, to me, in LAM patients, unless there was a very clear benefit, would not be taking your ovaries out, would not be the direction that I would go, and I think we just heard that today. But what about pills? So we think about this in the breast cancer space. So oral contraceptives, what they do is they suppress ovarian function. And so although we are giving you estrogen with oral contraceptives, it's a little bit unclear whether or not we're actually adding gasoline to the tank or whether or not the estradiol levels are actually lower. In my mind, with some of the very low dose oral contraceptive pills, I'm not sure that's an absolute negative, because many times when we give women very low dose oral contraceptive pills, they actually have hot flashes like they're menopausal. But I think in general, the LAM experts would tell you that oral contraceptives are not the first line therapy. Where I think it also gets a little confusing is what about IUDs? So there's two types of IUDs. There's one that has progesterone in it. There's one that does not. So the Paragard is the one that does not have any hormones in it. And certainly I think that would be a very reasonable option for LAM patients. The problem with the Paragard is that bleeding tends to still be heavy, and some women don't like that. The progestin-containing IUDs, and this is different than Depo-Provera, it's very low-dose progesterone in the tip of the IUDs. This makes bleeding really, really light. I personally think that this would be very appropriate for LAM patients, but again, I think there is some controversy about whether or not progestin is part of the problem in LAM, and I would defer to LAM experts as we're having this discussion. Okay, so what about menopause? So this is, again, a very typical patient that I see in practice. So what we know across the board is when women transition through menopause, about 30% of them have very mild symptoms and don't know what all the fuss is about. Another 30% have mild to moderate symptoms and can manage it with lifestyle, and another 30% are the patients that I see in practice who are absolutely miserable and having drenching, incapacitating night sweats, and all kinds of symptoms. And so we'll say that that's this patient. So, you know, we've seen all these slides, right, and there's the 7 dwarves of menopause, and I will tell you that as a woman who had chemotherapy-induced menopause, I can tell you if you are one of the unfortunate ones to be in the 30% of the category with severe symptoms, it really is pretty miserable and really can be very disrupting to your quality of life. By definition, menopause is no menstrual bleeding for 12 months. In the United States, natural menopause, the average age is 51. Induced menopause is menopause by surgery or by chemotherapy. So this is women who are having complete hysterectomies or getting, as I did, chemotherapy for breast cancer. Perimenopause is this vague, nebulous term. It's a transitional time, and probably everyone in the room knows that in the mid-40s, fertility drops off very quickly. And what's happening is the ovaries are just failing. Everything goes downhill after 35, and after 40, the ovaries really fade pretty quickly. That's why the quality of the eggs are not good, and the hormone production is inconsistent, and so really fertility goes down. What women really notice, and I will tell you, women can tell. Women know when they're perimenopausal. There's not a blood test to tell you when you are because hormones are all over the map. But it's really this 4 to 6 to 8 years when women are transitioning from a very robust reproductive period to the postmenopause. And women are symptomatic here. So what about menopause? So now in our country, women spend 1/3 of their life beyond menopause, and this was not the case a long time ago, right? So the average life expectancy now for women is 80. 100 years ago it was 55, and so now we really are spending 1/3 of our life as postmenopausal women. And vasomotor symptoms, I told you, are very, very common. 50 to 80% of women have them. 30% of women, 30 to 35, have very severe symptoms. They're more common in African American. In most women, but not all, 85%, and probably it's a little bit lower than that, they resolve within 5 years of that final menstrual period. And 10 to 20% of women will have persistent hot flushes throughout their lifetime. How do you know how you're going to do if you're a woman? Really, the first question to ask is, how did your mother do? So if your mother had natural menopause and had a hard time, you are likely to have a hard time. If you are African American, you're likely to have a hard time. If you had symptoms during the perimenopause, you're likely to have a hard time. Depending on your body weight, you're likely to have a hard time. Suddenness, so chemotherapy or surgically induced menopause, abruptness of menopause tend to have the hardest time. And then smoking and alcohol correlates very greatly. So the first thing I talk to about with my symptomatic patients is stop alcohol. And I will tell you, women come in all the time saying to me, I don't know what it is. My hot flashes aren't that bad during the week, but gosh, on the weekend, I don't sleep and I'm awake sweating all night. And I can tell you, if you ask them, it really correlates with, they're out socializing and they have a couple glasses of wine that night. So there's lots of other menopausal symptoms, and I will tell you, I won't go through all of these, but I will tell you that it's a very turbulent time for women. The one thing I want to point out is weight gain. So after hot flashes and night sweats, the thing that women complain about is weight gain, and this is really the one evil thing that I don't think anyone tells you very much, is that what happens with the loss of ovarian estrogen production, you have a complete shift in where you deposit body fat. So women, even when they did not have abdominal fat prior to menopause, with menopause, you start to see quick gain of abdominal fat, even if the scale doesn't change very much. What's happening is you have loss of lean muscle mass and you have an increase in percent body fat. And so what's happening is your daily caloric needs go down. So if you've been used to consuming 2,000 calories a day and your weight's been stable, now you're postmenopausal and you're consuming 2,000 calories a day and exercising the same, you start to gain weight. And this is one of those very frustrating things, and it's one of the reasons that preserving muscle mass is very important for women as they age. So it really, with your exercise regimen, it needs to be a combination of weight-bearing exercise as well as aerobic exercise. So this slide I just put up here to just say, everyone goes through menopause, so why do we treat it? And I told you 30% of women are absolutely miserable, and there's a lot of physiologic effects that happen with menopause. And so hormone therapy. So I'm going to go through this very quickly just to set the stage. So hormone therapy, and again, this is in general population. This is not in breast cancer survivors that I'm going to talk about, and this is not in LAM patients. But I just want you to understand a little bit of the data about hormone therapy. So there's definitely benefits, and you can see it is the absolute best thing to treat hot flashes and night sweats without question. 90 to 95% effectiveness. Nothing works better. It helps with the insomnia, it helps with sexual function, decreases colon cancer risk, decreases diabetes risk, and decreases that abdominal fat deposition. The big thing for me is women on hormone therapy who have been miserable with menopause clearly show an improved benefit of quality of life. But there's lots of concerns about hormone therapy. These were covers of news magazines in 2002, which is like ancient history now, but it changed the world in terms of the way we think of hormone therapy because there was the first part of the Women's Health Initiative data was published showing an increased risk in cardiovascular disease, breast cancer, stroke, blood clots, and dementia. So very, very scary. And I will tell you, at this point in time, the vast majority of women dumped their hormones in the toilet without ever talking to their doctor. There was such a media firestorm. And what really was out there touted is a 25% increased risk of breast cancer, a 30% increased risk in heart disease, and a 40% increased risk of stroke. Women heard that. These are, again, not LAM patients and not breast cancer patients. These are average women, and they dumped their hormones in the toilet. The problem is this was really a misrepresentation of data, which I'm going to tell you about. But this data led to this class label boxed warning on any estrogen product that any of you ever pick up, birth control pills, hormone therapy, postmenopausal hormone therapy, or vaginal estrogen, which we're going to talk about, which says if you take this medicine, you have a higher risk of stroke, myocardial infarction, breast cancer, pulmonary emboli, and dementia. So women have become incredibly fearful of this medication. But when we look at the data, you can actually see that the numbers are really small. This is per 10,000 women, and I'm going to show you how to apply this. There was 8 extra cases of breast cancer, which is what led to this 26% increase. 7 per 10,000, 7 extra cases of extra heart attacks, and 8 extra cases of stroke. These are real numbers, but they're small, and I'm going to tell you how I talk to patients about it. So, as a breast cancer survivor, I can tell you, and everyone in this room, the biggest risk of having breast cancer is being female and having breasts, okay? There are ways to have an individual risk assessment done, and it's another area that I'm super passionate about. But if we just look at population, if I take 100 women, 100 of you in the room, and I follow you for 10 years, from 50 to 60, you're not on hormone therapy, 3 women will develop breast cancer in 1,000 patient years just because the biggest risk of breast cancer is being female and having breasts. If I put all 100 women, different 100 women, on hormone therapy, high-dose hormone therapy for 10 years, same 1,000 patient years, now 4 women will develop breast cancer. That's 1 extra case of breast cancer in 1,000 patient years that we can attribute to high-dose hormone therapy that we don't even use anymore, and probably the specific type of progestin. So it is worth talking about, but it's not the huge, scary risk that's all over the media. But what about LAM patients? So I would tell you again, I would add LAM patients to this discussion of people that I would say, you know, if you come to see me with menopause symptoms in LAM, I am not going to give you estrogen therapy. I told you all that data just to, again, kind of put it into perspective because we're going to talk about vaginal estrogen as well. So I won't give you estrogen. What will I talk to you about? Well, so certainly lifestyle, mind-body activities, non-prescription supplements, which I'm going to mention briefly, and then there's certainly a whole host of non-hormonal prescription medications that I use, and I use all of these for breast cancer survivors as well as LAM patients. So in terms of lifestyle, there's definitely things you can do, and I can tell you that I am the queen of this now. You can see that I'm wearing a sweater. I take things on and off 10 times. My patients laugh at me now because I literally, in one patient visit, might take my sweater on and off twice. Layered clothing definitely helps. Again, no smoking, avoiding alcohol. Exercise has been shown to be beneficial, avoiding caffeine, and certainly stress is a big hot flash trigger. In terms of complementary and alternative medicine, so certainly there's things that there's And the data's mixed, to be totally honest with you, but I definitely recommend this for patients to try, right? I think the thing that has the most data to support it is actually paced respiration and relaxation techniques. The data on acupuncture is mixed, but I certainly recommend this for patients, and there's lots of other health benefits from some of these things anyway, and so it's always good to try. In terms of supplements, I will tell you I am not a big supplement proponent, largely because the clinical trial data is very mixed, but the biggest thing for me is they're not regulated like FDA prescription products. There's always a concern about impurities and safety. Most of the time they're safe, but I don't like most of the time, right? So we know from samples of products that have been independently evaluated that some products over the counter have 0 active ingredients, some have 400 times the active ingredient. There's impurities that can't be identified, and so I just in general don't love supplements. The ones that are out there are soy, black cohosh, vitamin E, red clover. I really don't recommend kava kava, and the one I will talk about a little bit is Relazin. So what about soy? So soy can be part of a healthy diet, but again, soy is a phytoestrogen, which means it's a plant-based estrogen. It's a weak estrogen. It does bind to the estrogen receptor. In general, for breast cancer patients, we do not encourage a lot of soy, but we do not specifically say you can't have any soy. I would say the same thing for LAM patients. Soy, it definitely has a little bit of activity, but it's really weak. For you to get a good, and women who are having bad hot flashes who try to take soy, it doesn't really help because you have to, as this slide says, consume so much to get any benefit of binding to the estrogen receptor that really it doesn't really have much impact. So although I would tell you not to completely avoid soy, I certainly wouldn't be having you take a lot of soy supplements because I don't think it will help. Relazin's a really interesting product. Actually, one of my colleagues and friends at NYU, Steve Goldstein, did this research on this product. It's actually a bee pollen. It's actually being manufactured in a way that I have a little bit more confidence that there's no impurities. It acts a little bit like antidepressants, which we use for hot flashes, and there is some randomized trial data that looks at efficacy. Because it's non-hormonal, I would not be opposed to a LAM patient trying Relazin. What about prescription products? And I've highlighted the 3 that I use the most. So the antidepressants work. The one that I use the most is Effexor, and the reason I use venlafaxine the most is because it has a really wide dosing interval, and I can start low and I can find exactly the right dose. The others I use are gabapentin, particularly if someone's having hot flashes, night sweats and are not sleeping. Gabapentin can be a little bit sedating and can be very helpful. But the one I'm most recently using, which has the least data, but has been highly effective for me personally, and in my practice I've been using it a lot now, is oxybutynin, which is a bladder medication, non-hormonal. There's really only 2 trials that are published right now. The reason we learned about oxybutynin being effective for hot flashes is actually in men with prostate cancer who have a lot of bladder symptoms after prostate cancer surgery and who are treated with Lupron, and we put them basically into a male version of menopause. They're having hot flashes, and when we give them oxybutynin, their hot flashes were better. So we studied it in women, and it works very well. You can tell a little bit of a dry mouth related to it, but other than that, in general, very well tolerated. There's one interesting thing on the market that I will mention, Duavie. This is a very interesting product. It is an estrogen plus a molecule like tamoxifen, so it's a SERM. So it's a combination medication. So the CEE is the estrogen part. The basodoxifin is something like tamoxifen. It definitely works for hot flashes. There's some animal model data that decreases breast cancer risk because it has some anti-estrogen properties. It certainly is not indicated for breast cancer patients, and it's not indicated in the label for LAM patients, but if I was a researcher, I would be very interested in studying this molecule in LAM patients. So how would I approach this patient finally? So she's a LAM patient. She's really symptomatic. She clearly has a contraindication to hormone therapy. She's tried all the acupuncture, massage, didn't work. I would try either venlafaxine or paroxetine, which I didn't mention, gabapentin, or oxybutynin for her for symptom control. But I would really be talking to her about risk-benefit in trying all of these medications. The one thing I will tell you is and I have a slide at the end when I talk about sexual dysfunction, is that the antidepressants, the one thing about them is in menopausal women who are already having sexual dysfunction, the antidepressants can add to that. And that's another reason that my go-to medication now for hot flashes is oxybutynin. And finally, so this is a 55-year-old woman who's 5 years postmenopausal with LAM, who has low desire, severe vaginal dryness, pain with intercourse, that she's tried over-the-counter stuff, and 2 UTIs. So what's happening to her? Well, first of all, I want to make a claim. Providers are not asking about sexual health. We know this in the breast cancer survivor population. If you can imagine, at big centers like MD Anderson and Memorial Sloan Kettering, where we do chart reviews, 25 to 30% of cancer survivors ever have a clinician ask them about sexual health. It's an area that I'm really passionate about, and clinicians are uncomfortable with the topic, and I think many of them don't really think that there's anything to do. They don't really know how to treat it, and I would encourage any and all of you in the room, if you're having sexual dysfunction, to really please bring it up with your clinician. And if your clinician is not really comfortable talking to you about it, ask for a referral. So, in women, sex is complicated, and that's one of the reasons that women's sexual health does not get addressed. And I love this slide from my good friend, Dr. Cheryl Kingsburg in Cleveland. Men, really, sexual health largely correlates with testosterone. In women, it's much more complicated than that, and this is the slide that I use to describe it. So clearly there's medical issues, breast cancer, other illnesses that impact sexual function, medications, hormone levels, sexual self-image, stress, kids at home, spouse that's ill, divorce, job stress, the quality of the relationship with a partner, your underlying culture and belief systems, whether or not you're anxious or depressed, and early childhood experiences. And so all of these things, when I'm doing a sexual health consultation, I try to quickly evaluate in my 5-minute visit. No, I typically have an hour for a sexual health consult now. Sexual health complaints or sexual health issues are very common. So this is a large study of healthy adults, 32,000, 12% of the population have sexual health concerns. What I'm going to talk specifically about quickly, and I know I'm running out of time and I'm sorry, is 2 common sexual health, the most common sexual health complaints. So we're going to talk about vaginal atrophy, which has now been renamed genitourinary syndrome of menopause, and hypoactive sexual desire disorder. So we know that menopause gives you hot flashes, but the other thing it does is it really impacts sexual function. So you can see in women who are just transitioning through the menopause, you can see here that 42% of women will be noticing vaginal dryness and some sexual complaints. The one thing that does not get better with time from menopause, so hot flashes typically get better, but what gets worse is sexual function. So by 8 years from the last menstrual period, 88% of women are having issues. And what are they having issues with largely is vaginal atrophy. And this term, the reason that a group of us worked to change the nomenclature was because women didn't like this term atrophy. They felt it was wasting away, sick, useless, aging. And you can see that there are really changes. This is a pictorial of a vulvovaginal tissue on the left in a premenopausal woman to a woman who's 10 years beyond menopause. And you can really see you have complete shrinking of the introitus and the vulvovaginal tissue in addition to thinning. And I will tell you in practice, women are amazed. Every single time I do an exam on a patient for a sexual health consult, I get a mirror out, they're in stirrups, I show them, we do vaginal pH, I point out where the tenderness is, because women don't look and they don't actually realize that the symptoms that they're having related to dryness and pain and burning is related to menopause, and that there's real physiologic changes that have taken place. And so what's the scope of the problem? So we know there's 64 million postmenopausal women in the United States. 50% of them are suffering with GSM. Only about half of those seek treatment. And what we know that only 7% of women are being treated. 7% of women are being treated, 7%. I will tell you that it's a lot higher in terms of men with erectile dysfunction being treated. This is really one of these Me Too gender biases in medicine. It's something that I'm very passionate about, really addressing the unmet needs of women. And the big thing here is that many women don't realize that symptoms of vaginal atrophy get worse with time. So if you're having problems and you're not treating it, it's not going to get better on its own. You really need to do something. I was privileged to be involved in putting together a expert panel with the North American Menopause Society and the International Society for the Study of Women's Sexual Health to come up with a publication which was published in Menopause just this past May to talk about how do we manage sexual health in breast cancer survivors. The reason I point this out is because this is exactly how I would manage patients with LAM. So the first thing we start with is moisturizers. So moisturizers are not the same as lubricants. Moisturizers are like face cream, that you put on your face every night to moisturize your face before you go to bed. Moisturize are to hold moisture in the tissue and need to be applied regularly. There's lots of them over the counter, and many of them work very, very well. They just have to be used. Lubricants are products that are used with sexual activity. There's two types, water-based and silicone. I typically recommend the silicone. I encourage women to apply it to them and to their partner, and they can be very helpful for making sex comfortable, and it's certainly a first-line therapy for everybody. We know that there's some data that shows that if used regularly, they can be very effective. And I personally, in my practice, sell products that I like and that I'm comfortable with. But these are two organizations that I would encourage you to go to if you're looking for resources on appropriate lubricants and moisturizers. A couple other points. Pelvic floor physical therapy is something that is underutilized. We do a really bad job in the United States of recommending pelvic floor physical therapy and talking about pelvic floor health. The UK and Europe and France and Italy do a much better job than us. Pelvic floor muscle tone, it can be too tight or it can be loose, really impacts sexual functioning. So I'm always examining women and talking to them about this. I have a pelvic floor physical therapist that works with me in my practice. Vaginal dilators can be very needed and very important and very helpful. And I talk to patients, and in appropriate patients who are having difficulty, recommend these all the time. Okay. Hormones, estrogen is the gold standard, and the good news is we finally, you can see there's a big gap between 1999 and 2010. And why was that? That was that evil WHI study which made estrogen bad for everyone, so none of the pharmaceutical companies wanted to do anything in the women's health space. But the good news is we now have some new products, two of them that I'm going to talk about specifically, Intrarosa and Imvexi. Those are the brand names that have just recently come out that I think offer an interesting possibility for breast cancer survivors as well as LAM patients. So is vaginal estrogen the same as systemic estrogen, which I told you I would not use in LAM? Well, so the issue is systemic estrogen we use for, so that's patches and pills orally, is what we use to treat hot flashes. Systemic estrogens raise serum estradiol levels. We don't want to do that in LAM. You've just heard that there's data to show that lung function declines more rapidly in the premenopause compared to the postmenopause. But what about local vaginal estrogen? So I would tell you that local vaginal estrogen, I believe, is an appropriate therapy for breast cancer survivors in the right circumstance, as well as LAM patients. And why is that? I want to just compare for you the difference between one M&M and a jar of M&Ms. Oral contraceptives, so birth control tablets, one tablet of birth control contains 1 milligram of estradiol. Vaginal estrogen tablets contain 10 micrograms. When you use vaginal estrogen, if you use the Vagifem, which is 10 micrograms, you can go a year, 1 year of therapy, not 1 month, before you have one equivalent of one birth control pill. If you use the newest, lowest dose of vaginal estrogen, which is the Imvexi, you can go 2 years before the estrogen is equivalent to one oral contraceptive pill. Serum estradiol levels do not change. They don't bump even with the new the ultrasensitive estradiol testing, and I would tell you vaginal estrogen is okay to use. We've been working to try to get the FDA to change the package labeling, unfortunately unsuccessfully. Again, I told you that all estrogen products contain the same labeling, even though, again, it's like apples and oranges. The doses are so completely different, it doesn't make any sense, and there's no data about increased stroke risk, heart disease, or breast cancer with vaginal estrogen alone. Intravaginal DHEA, so this is one of the two new products I'm going to touch on briefly. Intrarosa, it is not estrogen, it's DHEA. DHEA is converted into estradiol and testosterone, and the believed mechanism of action is that this is taken up into vaginal cells and converted into local estrogen and testosterone. It works incredibly well. It's a vaginal suppository. It does not have the boxed label that estrogen did. The FDA put this through without putting the boxed label on it, which all of us find quite interesting because it is converted into estrogen. But again, serum levels don't bump. Imvexi has just been on the market now for about 8 weeks. It comes in 4 micrograms and 10 micrograms. I think this is a terrific product because it doesn't have an applicator. It's inserted with a finger. It's only twice a week. It dissolves almost immediately, and it is super low dose, no serum bump in estradiol levels, and it works really, really well. Patients, I've been using it now for about 8 weeks, and feedback has been terrific about this. But I want to just say that, again, there's been no head-to-head trial on any of these products in either breast cancer survivors or certainly in LAM patients. But I would tell you, for the reasons I did tell you, I think that, again, I want you to just hear, if you take one thing away, vaginal estrogen or vaginal DHEA is a completely different animal than systemic estrogen. And I do believe if you are a woman with LAM who's failed conservative therapy, that these things should be an option for you. The one thing I'm going to quickly mention is vaginal lasers. This has gotten a lot of press in the last couple weeks. There are several lasers on the market. The lasers are FDA cleared, not FDA approved. What they do, and I will tell you transparently that I do have one in my practice that I use very selectively in appropriate patients. It's like doing laser on the face, which there's lots of experience with. It creates micro perforations in the vagina, which stimulates collagen and elastin, and many women who are unwilling or it's contraindicated to use any of the local vaginal therapies do get some benefit with laser therapy. But, and I'll skip this, what I want to make sure you hear, though, is treating vaginal atrophy or that genitourinary syndrome of menopause is not the same as all the buzz out there right now about vaginal rejuvenation. So as a person who sees a lot of sexual health consults now, there's a lot of new devices and technology out there to change the shape, the tightening, the loosening, the labia, labioplasties, vaginal bleaching. There's all kinds of things going on to try to rejuvenate the vagina, which I feel very strongly that the vagina does not need rejuvenation, and that that's really a marketing term. I do really believe, as I told you, though, that genitourinary syndrome of menopause is a very important medical condition that should be treated. These are all the new devices out there that many of you may seen or hear about. There's radio frequency, all different lasers. I just got an ad now for a home laser treatment. Buyer beware, be careful consumers, find out what you're doing, make sure you're getting informed consent. And remember that these devices are not the same as medications, they're cleared. And the data and the trials are really, really, really small, and it really is consumer beware. Just on July 30th, the FDA came out with a warning, which I thought was long overdue, as I've seen this explosion. And again, I have a laser and I use it in very selective patients, but again, if you are a consumer, be very careful that you are having a physical exam before anyone is putting a laser anywhere near you. And that you're learning about all of the various options before you're doing it. This is a great movie on Netflix that really, I think, will chill your bones about the device industry compared to the pharmaceutical industry. And finally, if I'm going to treat vaginal atrophy in LAM patients or sexual dysfunction, again, I start with moisturizers, dilators, lubricants, and pelvic floor physical therapy. I really would consider vaginal DHEA or vaginal estrogen. I might consider laser therapy and maybe even ospemifene, which I didn't really talk about. And finally, libido is also an issue in menopause. So testosterone levels begin to decline at age 35, like bone health and everything else goes downhill after 35. And women around the time of menopause, when they lose estrogen, often become very symptomatic about their low desire as well. And there's all kinds of funny slides, right, about low desire in women. So what we now really have come to understand is that there's two really components to a biologic basis of desire in women. And again, that slide with all of the bubbles that I showed you, it's not always biology. There's a lot of relationship issues and body image issues that can impact desire. But we know that there is a central nervous system basis to it, and that hormone levels, neurotransmitters really do impact level of desire. This is how the drug Addyi works. So many of you may be aware that Addyi's had a bumpy road in the last 2 years. It's got a lot of negative press. It's been touted as the female Viagra. It is a medication that in some patients is very, very effective. It rebalances dopamine and norepinephrine. And certainly is out there and FDA approved and available, and I certainly use it in appropriate patients. The other thing is testosterone, and again, I would tell you, because testosterone is metabolized into estrogen, I am very opposed to high-dose testosterone pellets, which some patients find their way to anti-aging and hormone centers and are getting pellets. very high dose testosterone. I would tell you I discourage that in breast cancer patients. I would discourage that in LAM. But there is guidance from the Endocrine Society that low-dose topical testosterone can be used in a short-term trial, and this is, again, I use this cautiously, infrequently in women to just try to bump their testosterone level back into the range where it was when they were in their 30s, not trying to get it in the super therapeutic range, and some women do respond to this. Last slide is just to tell you that antidepressants really negatively impact sexual function. So if you are a patient who has LAM, who's having sexual dysfunction, and this can be low desire and orgasm issues, the first thing that I will work on, certainly before going to Addy and before going to testosterone, is to try to change your antidepressant regimen. Wellbutrin is one that actually has some pro-sexual effects and may be very helpful either in combination or by itself in women who need it. And don't forget vibrators. So with age, clitoral sensitivity goes down, and I actually recommend these to patients as a medical device, not as a toy, and they can be very helpful. Thank you. So I think we're happy to stay to take questions, but feel free to get up and leave because I did go a little over, and I'm sorry. But you want to come up? I think we're happy to take questions if anyone has them.
I had a question that maybe both of you guys can answer collectively with your combined expertise, but what are your thoughts on egg harvesting and the impact on LAM progression, given that it's a shorter exposure to an estrogen dose?
Thank you. Can you hear me okay? Can you hear me okay now? Yeah. So egg harvesting, yeah, so actually the incidence of fertility problems in women with LAM is probably higher than the general population. Quite a lot of people have been through IVF and egg harvesting procedures that we end up seeing. And during this period, they have a fairly intensive period of ovarian stimulation, which, although may have an effect on LAM, we've never seen any direct association between the procedure and progression of LAM, although no studies have been done. So on the whole, I mean, personally, I don't discourage it. I don't know.
I agree, but maybe I missed the last part of your question. Was there something else specific about that?
Oh, no, I was just asking because I know sometimes it's discouraged for during pregnancy because it's a prolonged exposure to estrogen, and so I was wondering if you guys had seen anything in terms of the impact for a shorter dose for egg harvesting, even though it might be higher, but a shorter span of time. So
I would
think you
agree
answered the
that it's
question.
relatively short term, and I think I would be okay with it.
So in regard to the intravaginal products like Intrarosa and the Premarin cream, are those things that you just use as needed? Is that something you use every day? And then is it safe to do that, to use those long term? And,
So I tell all patients that they can and should use vaginal products, vaginal estrogen, for indefinitely, right? So the creams in general, we worry a little bit more about because women can overuse the creams. And so the creams we do sometimes, if you put a lot in there, see a peak level that's above the menopausal range. The tablets, Imvexi and DHEA, and even the Vagifem tablets, really we do not see levels anywhere above the postmenopausal range, and even with the ultrasensitive testing, we don't see even a significant bump, right? So in that paper that I was involved in publishing in May in Menopause, if you wanted to look at that, that's a very good review of, again, it's in breast cancer survivors, but it really goes through all of the data, what we know about vaginal estrogen in breast cancer survivors and how we think about using it, even again in someone like me or patients who have hormone-sensitive breast cancer. And I do think we think it's okay in certain circumstances to use it long-term again. And so in LAM patients, I'm really comfortable with using that, and I probably would start with the DHEA, and I say that without really having any head-to-head data. It's kind of a gut, and there's no data for me to tell you that. But probably I would do the 4 microgram Invexi or the DHEA. The Intrarosa is daily, and that's one thing that sometimes women don't like. The Invexi is just twice a week, and it's easy. You can do it. Doesn't have to be at bedtime. It can be in the morning after a shower. It's very rapidly absorbed. Women will tell you that they can go exercise without any mess with it, and yes, I would tell you you could use it long term. If you're someone that's really having problems already, starting with the 4 microgram Invexi, I would tell you to just anticipate it may take 6, 8, 12, 14 weeks before you start to notice a lot of benefit. And I actually have women work with dilators at the same time. So if you've had a lot of that atrophy over several years, it takes a little while to get things going again. But I have a great story that I tell all of my patients who are having trouble. Is I had an 80-year-old woman who had not been sexually active for 20 years, living in an assisted living facility, fell in love, came in, wanted to resume sexual activity, and really over a 3-month period of time with dilators and vaginal estrogen, we got her very happy again. And so it can come back. So that's one of the things I would just really encourage everyone is if anyone is having issues, it's one of the good things is really with appropriate care, we really can fix it and get it better. And I say this to my breast cancer survivor patients all the time too.
Do you see LAM patients who have other female health issues like endometriosis? And I have a friend who has that and is getting treated with estrogen. And I was just wondering if there was any alternative to do that or to help with that. If
You want to take it? So I'm interested that someone with endometriosis is being treated with estrogen, not anti-estrogen. So I'm uncertain about that. In general, we try to use ovarian suppression with bad endometriosis, so either oral contraceptives or Lupron. I don't know if she's on an anti-estrogen therapy and getting a little bit of estrogen back just to take some of the side effects away. So I'm struggling to answer that question a little bit. I don't know if you have a different take.
I have the same issue, really.
So we talked about pregnancy and LAM. Can you tell something more about surrogacy? Like, do people go for that, or is it advised or not advised?
Well, gestational surrogacy is certainly an option for people with LAM who either want to avoid the risk to their health, or maybe they have more advanced disease and pregnancy will be particularly dangerous for them. And there are certainly women with LAM that have undergone egg harvesting and have had children through gestational surrogacy. So, it's certainly an option for people. When you think about whether to have children or not, the things you have to consider is your wishes about a family, and also you need to discuss with your LAM specialist precisely what the risks are for you rather than a general person. And I've looked after people who've been well throughout their pregnancy with LAM, have had no complications. I've looked after other people who've had very difficult times, and that's probably dependent on the individual's disease and history. And so when you're thinking about these issues and whether to go for surrogacy or whether to undergo pregnancy, you need to talk about your case with somebody knowledgeable, really. But surrogacy is certainly an option.
On that same topic, I was recently at a conference at NIH, and it was brought up about maybe we shouldn't be donating blood or organs. And so, given this whole topic, are you able to, if we use surrogates, are you able to tell if the egg is carrying any kind of LAM cell at all that would, I would hate to give it to some other woman that was doing a nice thing for me. So.
Okay, so that's an important question. We think for people with sporadic LAM, the change in the TSC2 gene that's usually associated with LAM is just in the LAM cells and themselves. Now, we don't completely know the source of LAM cells, but we don't think that it comes from the germ cells. It wouldn't be in the ovaries. Although it wouldn't be an issue for the woman carrying the child, the only time when you can get a TSE2 mutation in ovaries is if you have tuberous sclerosis, and then 50% of your ovaries would not be a problem, no.
Is there a contraindication using hormone therapy for transplant patients?
So, hormone therapy as in, say, HRT post-lung transplant, if someone had LAM. You get tricky questions here, don't you? So, probably not. I mean, there would probably be residual LAM cells, so it's probably not the best option. Clearly, post-transplant, there are always issues with osteoporosis and other estrogen deficiencies. And so it's a difficult point. I think it would have to be taken on the individual. If somebody who's doing well had a double lung transplant, so not much residual LAM tissue left, then it would probably be okay. But again, it's an individual thing. Lisa stood up.
So I think this is really controversial. It's a really complex decision, and I think it really depends on the age of the transplant in the individual. Again, if this is a 28-year-old versus a 42-year-old versus a 55-year-old, right? I think the discussion is really, really different. Again, premature menopause. So if you have a transplant patient who really is completely amenorrheic and is basically had premature menopause, I would tell you that I think that the risk benefit probably would err on the side of being beneficial to do low dose hormone. And again, we really work in complex patients to look at where the estradiol level should be, right? So postmenopausal, it's under 20, and I told you in cycling women, it's 200 to 600. We typically, in premature menopause patients, shoot to the 80 to 90 range. So again, not as high, but again, it's a complex discussion. The older a person is with a transplant, then I start to worry about chronic steroid use and other immunosuppressant medications that they're on, and then thromboembolic clotting risk and stroke risk related to hormone therapy. So I'd be more reluctant. I think the risk would increase in older patients compared to benefit, and the benefit may be a little bit higher in younger patients, again, for bone, brain, heart health, to at least have a little bit of circulating estradiol around, but it's complicated. I don't think it's a right or wrong answer.
I have a question over here. My question is, in regards to my menstruals, right before it or a day or two into it is typically when I have a cyst rupture, or I will have a pneumothorax. So I was told that being on a birth control pill, which of course estrogen you can't be on, so it'd be progesterone, would be best to kind of help those symptoms and maybe make the transition smoother. But from the data showing that the progesterone really doesn't do anything and it's not necessarily good or bad, is it even worth, because I don't need it for the birth control purpose, but is it even worth being on it?
Okay, so this is an important issue. So progesterone may not affect the progression of LAM over 5, 10, 20 years in terms of preserving lung function, but if you can smooth out the fluctuations in estrogen throughout your cycle, if you have cycle-associated symptoms, then it may work for that. There isn't really strong evidence, but if your symptoms are difficult, it may be worth a try. If it doesn't help, you can always stop, but you want to give it a few months, I don't know, 6 months or something. So they're two slightly separate things, and although it's not guaranteed to be effective, it may be, and because it doesn't protect lung function, it doesn't mean it wouldn't help with those symptoms.
So I would say the same thing. So what you're really having is cyclic symptoms that really are significant for you, right? So your estradiol swings may be quite large. This is why I think I spent the least time, because I think it's controversial, on what you should do. All right, so let's just say for contraception. So progesterone-only oral contraceptives, as well as estrogen progesterone-containing oral contraceptives, suppress ovarian function. So your ovaries become quiescent, and we're giving you hormones back. So your estradiol actually may be lower, and you have evening of these hormone swings, which may be helpful. So a progestin-only oral contraceptive, I think, is a great thing to try for you, but I would also tell you that, and again, he's probably going to cringe, a 20 microgram low-dose oral contraceptive for you, I would try for you too. You're on a progesterone-containing oral contraceptive, right? So then it, it really becomes more complex about what other things maybe you should be on. In terms of not hormonal therapy, other therapy, and again, I don't want to put you on the spot about your specific care, but.
Dr. Larkin, are you seeing, I'm right here, do you see LAM patients, and are you at one of the clinics anywhere?
So right, as was said in my introduction, so I left UC in 2016, and I actually have a private practice here in town that does women's health and general primary care. So I definitely see LAM patients. Again, it's a consultant basis only, and I will tell you, I am out of insurance and out of Medicare, and I am just a straight cash practice. And it makes it cleaner and simpler, but again, it's not for everybody. I certainly have talked to Dr. McCormick and his team, and they have information about it. For patients who live out of state, I do some telemedicine consults as well. But again,
counsel us on email?
So email is harder for me because it's really not HIPAA secure. So the way that I do the in-person consults or even the telehealth is I'm using Epic, which is the electronic health platform, and the telehealth visits are HIPAA secure, so I'm nervous about doing too much. I've gotten a couple emails from patients, and I direct them to my practice manager to schedule because, again, I think email is not as good as seeing face-to-face and being able to have dialogue back and forth. It also isn't, you don't want me doing an email consult at 10 o'clock at night when I've had a long day. And it's just, I don't think it's good patient care, and it's not HIPAA secure, so I much prefer to do it otherwise. But again, there's, Dr. McCormick has other people in his team here in Cincinnati that are part of UC that I'm sure you could see as well. Again, my practice model may not be for everybody.
I just had one question about your antidepressants. You had a list of like 4 of them, and then a couple down here, and they had all 3 pluses across. Yes. The other ones had only maybe 1 or 2. Right. I didn't understand what the 3 plus. Yeah, right
so
there.
That's just a magnitude of the impact. So in other words, Prozac, which is fluoxetine, citalopram, Celexa, has lots of impact. 3 plus, all of those top ones have very significant impact on all of those domains of sexual function.
So positive or negative?
No, negative. So really, so the ones on the bottom are the ones, if you're having sexual dysfunction on one of the ones on the top, I switch you to one of the ones on the bottom because it has much less sexual dysfunction side effects.
Okay, can I take a picture of that?
Sure.
Okay, we'll do one more question. We're really running over on time. If you could either give your surveys to me or put them in the box in the back. And thank you both after this.
Hi. Throughout my life, I did have very difficult hormonal profile. My periods were never regular, ever. Miraculously, I got pregnant without extra help. But, and I'm getting close to menopause, and I'm definitely seeing some of the early signs. So what should I be looking for my health provider to be paying attention to, recognizing that I'm probably not a normal case?
Right, so the fact that you're in the perimenopause and having symptoms typically means that when you're getting close to that last menstrual period and you transition, that they may be worse. And so it's really up to you in terms of the patient, in terms of how you are tolerating your symptoms. If you can get away with doing lifestyle, exercise, alcohol avoidance, layered clothing, some guided imagery, acupuncture, and you do okay, then that's where I would stop with you. If you're really bothered, and again, this is what I see in consultant practice, the patients who are miserable, I would use, again, and I don't know if you're a LAM patient or not, so I don't know, but if you're a woman who can't take hormones, I would use oxybutynin or gabapentin to help you transition. Again, the majority of women, if we can help support you during that transition for a couple years, you really get better. So part of what I do with women is really just try to counsel them that it gets better. We got to get you through. It's, you know, the light's at the end of the tunnel for the vast majority of women, and we really try a lot of different therapeutic options. Thank you. Thank you.